the next topic, and that is from the private practitioner's perspective, Mumbai then and now. And we have Dr. Prakash Bora, who is going to give us overview.
One, it is lifelong infection. There is enormous psychological stress, and the change in lifestyle and behavior can change the course of the disease and in turn the epidemic. And there is associated stigma and discrimination. We all know these slides. The only thing to be remembered is 43% of the adults are on antiretroviral treatment in India. So what is the Mumbai connection with India? Mumbai is a mini India. Mumbai sabki jaan. So almost there are migrants from all over India, from all the states and many districts of Maharashtra. So the bridge population, the migrants who are coming from rural to urban areas, you can see that the 0.9% of the migrants are HIV positive as against the national prevalence, which is 0.3%. So this is very significant. So this is a Mumbai, which is this Toba Gardi. So Mumbai has been a fast-track city, number one. It has been fast-track, strong AIDS response. And the first AIDS activist in the form of our president, so he started the movement for the HIV prevention and the AIDS prevention. And this is the city with a formidable challenge and the opportunity. And this is a city where there is a fraternity, equity and inclusiveness. So now with this background, we go on to the area, the period. This is the story of 3 decades from 1986 to 2016. And there have been ups and downs, frustrations and satisfaction, hope and despair, helplessness and empowerment, and commitment and apathy. And this is the roller coaster ride which we have been all undergoing. The first came this 1986 to 1995, and we were walking on a thin rope. We were not having so many medicines, and we were dealing with lowest immunity. We were dealing with multiple OIs, multiple drug interactions, and basically the drained resources, inadequate facilities, and the stressed care providers and exhausted family members. There was frequent hospitalization. So in this period, there was some sort of hopelessness that what we can do, because there were no medicines as such, and most of the practitioners, those who started doing this, they had their social outlook to help out the people. So this was the situation. There were no people to take care, and this is a child who is taking care of her mother. Then India on hit list, so was Mumbai in 2004. So India was entering into third phase of epidemic, and 15 to 20% of the Mumbai was occupied by sick HIV individuals. Then came the changing AIDS scenario. In 2005, 2007, there were more than 40% females. Orphans and widows were on the rise. And basically, there were patients who were coming to us from the police, from the best, from the private sector. And what I want to insist upon is that the middle class or the higher middle class patients who did not go to ARTs and government facilities, they were coming to private sector, and they have never come into statistics. And I feel that percentage-wise, probably the middle class had more patients than the lower middle class or the lower class financially. So after this background, let us see about the 3 aspects as a patient's profile. What are the changes in the patient profile? What are the changes in practitioners' empowerment? And what are the progressive socio-economic and healthcare changes which has changed the whole scenario? Earlier, there were issues with PLHA, which was vulnerability, stigmatization was the great thing, discrimination, exploitation, financial crunch. There was no access to therapy, and the family and community support was very much badly needed, which was not there. And then most of the practitioners, we were doing this social work of awareness, AIDS awareness. And during that epidemic, during those years, we found that the women, they were very strong and resilient, and they had taken up even though they were infected, they were affected, they had taken up the task and they had taken up the challenge. And this is what she lost her child, But now still she continues, she is on ART and she is still alive. So this was the get-together we had done for the positive people. And this was a get-together of positive people, doctors, and the other society members. And this was the awareness thing, and we wanted that discrimination should go down. But the game changer was ART. And there was mounting clinical experience and research. There were improved treatment regimens and diagnostics, significant reductions in the price of the medicines, thanks to all the pharmaceutical companies, and increased gains in the efficiency and the effectiveness of medicine. And that thing changed the whole thing. And there was a changing age scenario in Mumbai from 2007 to 2012. And we started to manage this as a chronic manageable disease. Accessibility, affordability, and availability of ART was increasing. There was reduced discrimination in the healthcare settings, and new STD HIV cases were on decline, and there was definitely increased awareness in PLHA and community. And the changing, profile of patients also changed. Their quality of life changed. They are leading a good quality of life for many more years now. They have become more confident. There has been a reduced fear of death, reduced fear of stigma, reduced fear of discrimination, and there has been overall acceptance in the society as such. And gender-wise, there are females and males, almost equal numbers, at least 40% females, and the family support is definitely there now. And you can listen to those, some of the testimonials from patients. I think it's not working or what? So now issues with PLHA are different from which were there earlier. So now they are worried about long-term adverse effects of the ART and basically the cost of monitoring. Though the cost of medicines have gone down, cost of monitoring is remaining same. There are social problems, especially about the marriage and all, still problems are there. And the major problem is about the adherence, because this is a lifelong infection. Adherence with the ART is really a big problem, and the retention in the treatment. And we do not find 100% retention in the treatment. Again, another problem is with the insurance. There is no mediclaim, and people who need it badly, they don't get that insurance, mediclaim insurance. And access to second and third line therapy, these are all the problems which are now PLHA are facing. There are changes in the profile of physician also. So practicing physician was a counselor, family friend, doctor in the early years. Now he has become more professional, more like a researcher, and more like a scientist. And more younger people are coming to this fold. Earlier, the components of management were prevention, counseling, therapy, nutrition, change of lifestyle. They still hold good. But in the early years, there was the emphasis on this, and now the things have changed. Now HIV management has become like a Mumbai traffic. Mumbai traffic is, there are encroachments, there is disregard to signals, potholes, wrong side overtaking, honking, and you have to navigate your way through this. So similarly, we have to navigate our way through the different problems which are there. Drug interactions are there, comorbidities are there, pre-existing medical conditions are there, and side effects of ART therapy. So all these things now we have to manage. So earlier we used to manage more of opportunistic infections, cachexia, disseminated tuberculosis, PCP, recurrent diarrhea, and there was definitely a problem to face the death. But now the things have changed. Now we have to deal with adverse events, we have to deal with drug resistance, treatment failure, malignancies, and age-related problems. So there is a changing profile of a private practitioner now. Earlier there was slightly hopelessness because there was no medicine. Now he is empowered with all the ARTs and very effective ARTs. Earlier when this started, there were more STD specialists who jumped into this, and they initiated initially the HIV management, and then later on the more physicians joined in. So earlier we used to have more social responsibility and commitment, and now I think there is some amount of a commercial approach in the private practitioner's way. And probably I think everybody who is practicing has become prosperous for the causes known or unknown. Now, earlier there was no time for documentation. We were bogged with the clinical work. So there was no time for documentation. But now there are well-equipped IT tools, and now I think the things are changing. There were few people who were burnt out, like were tired of the managing, and now there are people who have already done it, and they're looking for better avenues like cosmetology rather than doing this. So this is a change in the profile of a private practitioner. So now, right now, there may be about 30% dermatologists or aesthetic specialists who are taking care. There are 60% physicians who are taking care, and maybe 10% of ID specialists who take care. And there has been overall turnover is almost about 3 to 4 crores per month in Bombay itself of ARV. So it's almost come to about 48 to 50 crores annually. So this is something which is very remarkable. And there has been a changing clinical scenario. There is significant reduction in STD cases. We have not seen chancroid, donovanosis, LGV. Sometimes I start feeling whether I would forget the treatment of all those medicines, because I have not seen them for many years. Then there is significant reduction in the number of newly detected HIV cases, and there is significant reduction in OI and inter-hospital admissions. And another good thing is that because of the ART centers, because government is providing free ART, there has been a decline in the private patients who have been coming to us. In the end, I just want to stress that there is a need for change. Cost of investigation still remains a major hurdle even today. And in spite of 30 years of epidemic, medicines have come down, but investigations cost has remained same. And I think there is something has to be done for that. Stigma and discrimination had definitely reduced in healthcare setting, but it has not come to an end. And still there are instances where they have been discriminated, and it needs to be done. And thanks to the bill which has come in last week, and I think hopefully the things will be better. Still, adherence to universal precautions is lacking, especially in private nursing homes. And this is a worrisome problem. Quackery still continues to be a greater challenge. Even it was there also, and even now also. And again, Mediclaim insurance facilities are needed very badly. So the newer challenges are increasing complex treatment schedules. There are issues related to drug resistance, co-infections, treatment failure, and emerging new viral infections like Ebola and all other things which are coming up. So the points to ponder, as far as practitioners who are, I feel, I would like to open up for that national conferences should be an umbrella of a national body rather than having 2, 3, 4 conferences. And we can have localized workshops or regional workshops so that the people can attend and they can be more of a clinical value. Secondly, we must utilize pharma resources optimally, and we should combine their efforts for the betterment of the patients, for the betterment of the facilities, especially greater access to subsidized investigation facilities is very much needed. And again, greater interaction between public and private establishment. Now, right now there is something like we are on the crossing swords, this thing private and public part. So we need to change that, and we must highlight the success stories of the patients who have been living a good quality life for many, many years. So this is Bombay, and at the end, I would just like to tell that in spite of everything, we need to know that let us not discriminate. It hurts. People living with AIDS are people who have strengths and weaknesses, people who have qualities and frailties, people with wishes, hopes and fears, people with partners, loved ones and friends, and exactly the same as we are. And I think this is the theme which Manoj is going to take ahead. Thank you very much.
Can we have the question answer round post the session, because we are falling short of time. I would request Dr. G.D. Ravindran to present him a token of memento.